Hi everyone, welcome to my channel. Before you get started, please subscribe my channel and press the bell icon. The topic of this video is bronchial asthma. In this video, we will discuss about introduction, types, precipitating factors, phases, morphology, clinical features of acute asthma, clinical features of severe asthma, complications, examination, investigation, management, and difference between bronchial asthma and cardiac asthma. Let's start from bronchial asthma. Bronchial asthma is a sudden attack of breathlessness, chest tightness, and wheezing, resulting from paroxysmal narrowing of the bronchial airways. The narrowing of bronchial airways is due to muscle spasm, mucosal swelling, bronchial secretion occurring as a result of inflammatory reaction. In this image, you can see normal airways, asthmatic airway, and asthmatic airway during attack. Types. Bronchial asthma may be episodic, chronic, severe acute asthma, drug-induced asthma, and occupational asthma. In episodic asthma, the patient has no respiratory symptoms between episodes of asthma. Attack or wheeze and dyspnea may occur at any time and can be sudden onset. Precipitating factors may be allergens, exercise, and viral infection, such as common cold. Duration of attack varies from few minutes to several days. In chronic asthma, symptoms may be chronic unless controlled by appropriate therapy. These symptoms are chest tightness, wheeze, dyspnea on exertion, together with spontaneous cough and wheeze during night. Cough produced of mucoid sputum with recurrent episode of respiratory infection is common. Severe acute asthma. This term describes life-threatening attack of asthma. Acute and chronic both types may lead to severe acute asthma. It is a state of continuous or prolonged attack of asthma associated with severe respiratory distress and arterial hypoxemia. The respiratory symptoms are tachycardia, sweating, and central cyanosis. Next we discuss drug-induced asthma. Several pharmacologic agents provoke asthma, aspirin being the most striking example. Patient with aspirin sensitivity present with recurrent rhinitis, nasal polyps, and bronchospasm. Lastly, we discuss occupational asthma. Occupational asthma may be triggered by fumes, organics, chemical dust, gases, and other chemicals. Asthma attacks usually develop after repeated exposure. Precipitating factors include abrupt change in weather, cold air, dust, tobacco smoking, atmospheric pollution, exercise, usually at termination of exercise, emotional stress. There are two phases. In early phase, reaction is dominated by bronchoconstriction, increased mucus production, and vasodilation. Bronchoconstriction is triggered by mediators released from mast cell, including histamine, prostaglandin D2. In late phase, reaction is inflammatory in nature. Inflammatory mediators stimulate epithelial cells to produce chemokines that promote the recruitment of cells, eosinophils, and other leukocytes. The morphologic changes in asthma include thickening of airway wall, subbasement membrane fibrosis, increased submucosal vascularity, and increase in size of the submucosal gland, hypertrophy of the bronchial muscle. Clinical features of acute asthma: feeling of tightness in the chest, wheezing, episode of dyspnea, unproductive cough which aggravate the dyspnea. Clinical features of severe asthma: severe shortness of breath, cannot speak, cannot lie down, central cyanosis, unable to speak, exhaustion, relative bradycardia, unrecordable peak expiratory flow. Complications include dehydration, airway infection, exhaustion, pneumothorax, and respiratory failure. Examination: during mild attack, slight tachycardia, mild diffuse wheezing produce. During moderate attack, use of accessory muscles of respiration, decrease breath sound, loud wheezing, retraction of intercostal muscle. In severe attack, fatigue, inaudible breath sound with diminished wheezing, inability to maintain lying position, and cyanosis. Investigation: asthma is investigated by chest X-ray, peak expiratory flow rate, and arterial blood gases. A chest X-ray should be performed in all patients with poor response to treatment in acute severe asthma. In peak respiratory flow rate, measuring the peak expiratory flow rate with a simple, inexpensive device called peak flow meter can indicate the severity of airflow limitation. Predicted value for peak expiratory flow rate vary with gender, age, and height. Peak expiratory flow rate should be measured in morning, in the middle of the day, and before bed. Measurement of peak expiratory flow rate is helpful in long-term assessment of the patient disease and response to treatment. Arterial blood gases. Measurement of arterial blood gases pressure is necessary in the management of patients with severe acute asthma. Arterial blood gases may be normal during a mild attack, but respiratory alkalosis and mild hypoxemia are usually observed in more severe cases. Hypoxemia worse and respiratory alkalosis disappear when respiratory muscle fatigue prevent hyperventilation. Management. We manage asthma by follow these instructions. Prevention of asthma. Remove allergens from the home including dust, dust mites, cleaning chemicals, pets, and carpets. Use only allergen-proof pillows and blankets. Asthma patients should leave the house during cleaning. Drink at least 8 glasses of water daily to thin mucus in the respiratory system, airways. Stop cigarette smoking. Establish a no smoking policy in the home. Early treatment of chest infection. Now we discuss difference between bronchial and cardiac asthma. Bronchial asthma characterized by episodes of dyspnea accompanied by wheezing resulting from temporary narrowing of the bronchi by muscular spasm and mucus secretion. Cardiac asthma is characterized by episode of dyspnea which may or may not be accompanied by wheezing occurring in association with pulmonary congestion or edema. In bronchial asthma, history of previous periodic attack of asthma, family history of allergic disease such as rhinitis. In cardiac asthma, presence of cardiac risk factors such as diabetes, hypertension, smoking, family history, and previous history of angina and myocardial infarction. Bronchial asthma usually occurs in early morning, while cardiac asthma occurs in the middle of the night. Symptoms of bronchial asthma include dyspnea and cough with expectoration of small sticky sputum. Symptoms of cardiac asthma include dyspnea and cough with expectoration of watery and frothy secretion. Signs of bronchial asthma are chest may be barrel-shaped, only expiration is prolonged. No cardiomegaly. In cardiac asthma, chest may be normal in shape. Cardiomegaly is present. In cardiac asthma, crepitations are more prominent and murmurs may be present. Chest X-ray of bronchial asthma is normal or hyperinflation. Chest X-ray of cardiac asthma, cardiac megaly with prominent pulmonary artery shadow. ECG may show sinus tachycardia in bronchial asthma, and in cardiac asthma, ECG may show left ventricular hypertrophy. Pulmonary function test. Obstructive pattern in bronchial asthma. Thank you for watching. Don't forget to like, share and subscribe.